Hello everyone, and welcome to the first episode of the Understanding Sports and Exercise Medicine Research Show, the show that brings you the latest research straight from the horse's mouth. I'm your host, Tim Trevail from Torrens University in Melbourne. I'm here to support you on your journey through the complex world of health-related research. So why have I started this show? Well, in my experience, it's not often enough that we get to hear directly from the original researchers to understand their unique insights into their research. The delay between research and implementation into musculoskeletal healthcare practice has been evident for a while now. There are complex reasons for this lag, but part of the issue is the increasing difficulty in the readability of scientific papers for clinicians. Anything that we can do to help people to understand the research and reduce this time lag has to be in the interest of all stakeholders to improve high-value care. On a personal level, as a PhD student, I'm trying to better understand the research myself. As one of my supervisors, Dr. Peter Maliaros, reminds me, a PhD is a research apprenticeship, and by definition, I'm here to learn from those of experience around me. Speaking to the researchers directly helps me to understand their thought processes, methodologies, and clinically relevant take-homes of their research. I'm bringing this show to all those working in the field of sports and exercise medicine. The overall purpose of this show is to support clinicians and early career researchers to better understand the research and ultimately to help us deliver high-value and effective care to our patients and athletes. The show will be released on YouTube at youtube.com/timtrevail, where you'll be able to follow along and see parts of the papers under discussion. I'll be screen sharing relevant components of the journal articles to help you follow along. For those listening to the audio version, you can search for the Understanding Sports and Exercise Medicine Research Show on iTunes, and I'd certainly encourage you to access and read the full text to make sure you make the most of the show. But if you don't have access right now, I'll still be working to make sure you can follow along and get the main points just fine. We'll aim to keep the show to about 20 to 30 minutes per episode. I find that the ideal listening time myself, and probably fits into most commutes for those listening to the podcast version. The first episode is a little longer today, as we're treated by our first guest to 2 papers from his PhD research. Alright, I think that's about enough for today. If you find this useful, please comment and share. If you're getting something out of it, then the chances are that other people in your network will too. So without further ado, let's get into it. Hello everyone, and welcome to the inaugural Understanding Sports and Exercise Medicine Research podcast. Today, I'm delighted to be joined by Igor Sancho from San Sebastian in Spain. Igor is a physiotherapist with a special interest in Achilles Tendinopathy. He's currently balancing his private practice work in San Sebastian with his doctoral studies, where he's a PhD candidate at Queen Mary University of London. I was fortunate to meet Igor a little over a year ago while he was collecting some data in Melbourne as part of his PhD, and he's now produced some fantastic research with that data in tendon pain, and I'm excited to be able to be talking with him about that today. So Igor, welcome to the podcast and thanks for coming on.
Hi, good morning team. Thank you very much for having me. It's a pleasure to share this short chat with you and thank you for giving me the chance to spread the word and to talk about our research.
Excellent. So as we touched on just prior to the podcast, this show is really designed to help clinicians working with athletic populations in a range of settings, as well as early career researchers like myself to understand the research a little bit better. So in my opinion, there's no better way than to hear about it from the original researcher. So before we get into the paper, can you just tell the listeners a little bit more about yourself and your clinical background?
Yes, of course. Well, as you said, I'm based here in San Sebastian in the Basque Country in Spain. I graduated as a physiotherapist in 1998, so a long time ago. Since then, I've been working in my own practice for 20 years now, especially in sports field. Okay, so I have combined the work in the clinic with recreational athletes, but I have also worked with professional athletes. I've been working in rugby and for 4 years, and also 11 years with a professional basketball team. Okay. And in 2015, I was a little bit fed up of traveling and spending the whole weekend working, and I decided, I decided to get back to study. I had the feeling that I need to get deeper in the understanding of why some pathologies where I was able to improve them, or to help the patients, and all the patients with same pathology was more difficult. So I decided to give a step forward and go back to study. And I met Dr. Pete Mayaras in Madrid, and I really get along with him. And I decided to visit him in Melbourne. I spent a month with him, and well, everything was quite straightforward. And after that month, he asked me if he invited me to do a PhD, and I thought about it. I shared that with my family, and that's how I started. So it was quite challenging for me to go 3 years to Australia. And he introduced me to Professor Dylan Morrissey at Queen Mary University of London, and that's where we started the PhD. And they are my main supervisors. But I also have very good collaborators, like, for example, Dr. Christian Barton from Melbourne, or Dr. Rich Willey from University of Montana. And now more recently, I'm also working with a friend of mine, that it's Dr. John Lascurain from the University of the Basque Country. So that's a little bit what I'm doing now. So I'm a little bit now working in a part-time PhD and working at the clinic. I'm combining both.
Fantastic. Thank you, Igor. And so we're going to just talk about a couple, and these are the first two papers that you've produced out of your PhD program. So I can see you've got a great group of researchers that you're working with, and they're the same researchers across these two papers that we're going to be covering today. And the first paper is this systematic review, and we're going to spend most of the time looking at your second publication, the Feasibility Study, a little bit later on. But do you want to just tell us a little bit about the background as to how you got to this systematic review, and why you thought it was important to review this literature to really set up your PhD?
Yeah, well, I think my whole PhD aims to try to find what are the important things we need to target in the rehab of an athlete with tendinopathy. So first of all, we wanted to know how important biomechanics are. So we conducted this systematic review to identify and synthesize what the literature says about what are the biomechanical alterations that active people with Achilles tendinopathy have during running and hopping, because that's what we know. We know that especially Achilles tendinopathy, it's an important injury in people that run. That it's like between the 9 and 50% of the running injuries are Achilles tendinopathy. So yeah, we wanted to see how these biomechanical alterations were in these sports, not just walking, but doing something like stretch, short, and cycle activities. Okay, so because we wanted to know if understanding what the biomechanical alterations are, we could provide treatment and prevention targets. Okay, so this is what we did. So we conducted a systematic review with a meta-analysis, and we searched for different databases in July of 2018. And what we basically looked for was case-controlled studies, cross-sectional studies, and also prospective studies investigating kinematics, kinetics that included both joint moments and ground reaction forces, as well as plantar pressures, as well as neuromuscular activity in people with Achilles tendinopathy during running and hopping. Okay, so we used a modified version of Downs and Black for the quality to appraise the quality of the studies. And if you want to, I can go straight to the results. We found 16 papers that were eligible. Okay, from these 16 papers, 12 were investigating running, and 4 were based in hopping. 14 were case control and cross-sectional studies, but only 2 were prospective studies. Okay, so this is a very important thing, because we found from the 249 outcomes that were investigated, only 17% were different. Okay, but from these 17% that were different, only 3% of all the outcomes that were investigated were prospective. That means it was really difficult to find a causal relationship between the tendinopathy and the variables. Okay, so in terms of running, if we look at what the running papers were telling us, what we found is that only 10% of the kinematics were different between groups. Okay. And if we look into the meta-analysis, what we found is that there was no differences for the sagittal plane or the frontal plane for the ankle, for example. Okay, so we have heard that ankle dorsiflexion and ankle eversion are related to Achilles tendinopathy. For example, we know that excessive and reduced ankle dorsiflexion have been related to the presence of Achilles tendinopathy, and also it's very common to see papers or there's like a myth to say that if you pronate too much, that can be related to your Achilles tendinopathy. What we found is that meta-analysis said that there was no differences between groups for frontal plane and sagittal plane in the ankle. Okay, so this, for example, doesn't support Clement's theory of whiplash, okay, saying that we pronate a lot, and this twisting is what increases loads in the Achilles tendon, okay. We didn't find differences between groups for ground reaction forces, and for plantar pressure studies, we only included two. One was prospective and the other one was retrospective, okay, and it was difficult to, like, the relationship between both was conflicting, okay? So only two papers. I think we need to continue investigating how plantar pressures are affected. For joint moments, what we found is that from a single paper, it seems that there are altered moments in the hip. So there was increased moments at the hip. This is from Trevail colleagues' paper, okay? So, but this was cross-sectional as well. So we don't know if these moments are precede or are consequence of the Achilles tendinopathy. And finally, what we found was that there was neuromuscular alterations, like reduced and delayed activity around the heel strike and mid stance for both lower leg and hip muscles. Okay, again, these findings are retrospective. So, yeah, this is a little bit what we found in running. If we look at hopping, we can say that maximal hopping is less efficient in people with tendinopathy. Okay, so the way they hop, the spring is less efficient. Okay, so the limitations in general of this systematic review could be that there is a lack of prospective studies to say that, look, this biomechanical alteration, it's going to take you to have Achilles tendinopathy. Okay, so causality is we cannot support that. And the other one is that there was not so many outcomes that could be input in the meta-analysis. Okay, so if the meta-analysis telling us that most of the variables that were introduced for meta-analysis didn't find differences between groups, and the differences that we found are based in single studies. Okay, so I think there's there's a need to continue investigating this. So the future directions, I would say, in relation to this study is that we should also look at how pain influences the results in this study. For example, in neuromuscular activity, is pain related to this reduced activity, okay? And the other one is that we were looking, most of these studies were looking at mid-distance runners. However, they were investigating running in a treadmill for 30 seconds, okay? So we would like to know how these biomechanical alterations are in presence of fatigue. If we ask someone to run for 40 minutes, I'm pretty sure that the mechanics are going to be different than just running for 30 seconds, okay? So, and now the message for clinicians here should be, now that we know that there might be some neuromuscular activity alterations like reduced and delayed, or we might have some hip joint movement, increased movements, or that plantar pressures are different. How can a clinician address this? And if we are able to address this, if we change them, is that going to improve the symptomatology and the function of our patient? How feasible is to do that in the clinic? Okay, and also, even if we do that, should that be the base of the treatment, or is that an adjunct? Okay, because we know Achilles tendinopathy is multifactorial. Okay, so if we change biomechanics, is that going to be enough, or do we need to do something like, for example, manage loads or increase strength or different things? Okay, I think there's other potential factors that has not been studied in these papers. Okay, that might be very, very important to address, not just biomechanics. Okay, so if we look at intrinsic modificable risk factors, yeah, biomechanics can be one, but it's only a small piece of the puzzle. Okay, there's a lot of things that we need to address. Okay, and that might be more important, like especially load management, like the external risk factor. Okay, this is a little bit what I would say about the systematic review. I don't know what you think about it.
That's fantastic. No, I certainly enjoy reading the paper. As someone who's working through early stages of a systematic review at the moment, I thought it was really nicely laid out, clearly put together. I enjoyed the meta-analysis components, and I think it certainly clearly added to the research that we've got available at the moment. And I like the way that you framed it, as it's setting up the rest of your PhD and the wider studies. And with any of these papers, they've certainly got their limitations, and those are recognised within the paper. So that's good to see. Well, thank you very much for covering that. That was a fantastic overview of that paper, Igor, and I'm sure the listeners will really appreciate that. If we can spend a bit of time now, I'll just pull up the next research paper that we're going to get into. So just give me a quick moment. All right, so this is the primary paper that we're going to discuss today. So this is titled Education and Exercise Supplemented by a Pain-Guided Hopping Intervention for Male Recreational Runners with Midportion Achilles Tendinopathy, a single cohort feasibility study. And these are the same authors that you completed the systematic review with. So just firstly, do you want to talk a little bit around where did your idea for this topic come from? Do you just want to continue the conversation we were having around your sort of project as a whole, and why was this an important study for you to start with, and what questions did you have that really made you start to think about this methodology?
Yeah, sure. So I would say, like, historically, that management of Achilles tendinopathy has been quite challenging. So we were facing long-term recoveries, sometimes with high rates of relapse. Yeah, and it's as I said, we are talking about quite a common pathology in people that treat recreational athletes. So it's not that common in professional athletes, but more in like medium-age males that go twice per week for running. Also, we need to say that it can happen in more sedentary people. Okay, but yeah, typically it's like it's a running injury that occurs in like people that usually comes to my clinic. So I always had this feeling that we could maybe improve the way we were treating this. So we know that progressive loading of the tendon is now it's consistently recommended as the key treatment, right? And we do know that tendons respond well when the applied loads are high loads, around 70% of NDC or around 1 RM. We know that tendons respond better to treatments that are at least 12 weeks. And we do know that a pain monitoring system helps when we are treating subjects or patients with Achilles tendinopathy. Yeah. So And this is this data comes from a systematic review that Pete and Christian Barton did about loading programs for Achilles and patella tendinopathy. Sorry. But the most papers that they investigated were papers like Alfredson Protocol, Stanish and Kurwin, Konsgaard, Bayer. Yeah, so papers that are comparing different loading protocols, okay? But my concern here is like what they are basically doing is comparing high but slow loads, okay? So they are comparing heel rises, one leg, versus HSR heel rises with both legs or one leg, okay? But are movements that are slow, okay, where the rate of force development is slow. But when we think about who we need to treat, we are treating athletes, we are treating people that want to run, that want to sprint, that want to cut, okay? So for me, these are more like high, fast loads, okay? So between both things, I think there's a big gap there, okay? And that's the feeling I have, like the return to play phase is not completely restored. Yeah. So related to this, there's a paper by Silbernagel and colleagues from 2007 that what they did is after 1 year after they gave treatment, like a treatment that was combining exercises to people with Achilles tendinopathy, what they found is that only 25% of the patients, of the athletes that were that were symptomatically recovered, only 25% had fully restored their function. Okay, and this was measured with a test battery where they did counter movement jumps, some maximal hops, drop counter movement jumps, some heel rises, etc. Okay, so from this is telling me that maybe even if they did some exercises like bouncing and things like that, maybe we need to do something more. Okay, not just heel rises, or even if it's heavy. Okay, and then we have some other papers now that are the protocols that are recommended that are more based in maybe in experts' opinion. Okay, which are great. Okay, but I think as researchers we need to challenge these papers and we need to know if we can improve that. Okay, so what these papers now are proposing, are suggesting is that we need to start doing some isometrics, then we need to do some strengthening, then we go to functional strengthening, continue with the speed, then go to plyometrics, and at the last phase is return to play. As a clinician's perspective, in my opinion, what I think is that this takes too much time. And as soon as the athlete or the patient gets asymptomatic, as soon as people start running and hopping without pain, what they want to do is return to their sport. So if you are treating a runner, he wants to run. If you are treating a football player, he wants to play football, and like that. And don't tell them that they still need to go through the functional strength, speed, plyometric. I mean, if they don't feel any pain, they just want to go back. Okay. So for me here, most of the time we are missing this gap. Okay. So our hypothesis was, can we implement the treatment that we are providing, like education and the progressive exercises, can we implement it with a hopping progressive protocol? Is that feasible, okay, in the treatment of Achilles tendinopathy? That was our question, and that was the study we did. Okay.
Excellent. That gives us a good framework to understand why you've picked obviously this feasibility study, and you've picked a single cohort. Do you just want to tell us a little bit about where the participants came from, and for the readers that are following along with the paper, this is just we'll go down to the second page, 2.2 participants.
Yeah, Tim. Yeah, well, participants came from, I went to Melbourne and I started to ask for participants in the social media. I went to the parks in Melbourne. We were asking in other physiotherapy clinics. I asked in running clubs, in footy clubs. That's how I got these participants.
Excellent. And in terms of actually the inclusion criteria for those participants, do you just want to talk a little bit more about how you selected those people?
Well, we were looking for people that male people between 20, 60 years old that had to be active and with a minimum one running activity. So we cannot say they are like runners. We should say they are recreational athletes, okay? Because we allowed people that were doing some running in football or rugby, not just running, okay? And yeah, probably what that's the thing. And the clinical diagnosis, what they had to have localized pain in the mid-portion, pain with loading, and morning stiffness. Okay, confirmed by ultrasound diagnosis.
Okay, so it's a pretty standard Achilles tendinopathy clinical diagnosis.
Yes.
In most physiotherapy type clinics. Excellent. And just interesting to hear the actual pragmatics of a researcher. You have your inclusion criteria, but you still might be running around parks trying to chase people down to be included in your study. It's not always, they don't just fall into your lap, do they? So that's the pragmatics of research.
Yeah. Well, you know how I did it. Yeah. So yeah, I was new there in Melbourne, and it's like, okay, I need to go and find subjects. So yeah, that's what I did.
Excellent.
It was fun, though.
All right, so
okay,
we'll move on to the study design and the interventions, and I just want to understand a little bit more about the methodology here and the interventions that you included in this study. So, first of all, you've touched on this before, but can we just understand a bit more about the educational component that you included in the with your participants?
Yeah, well, basically, sometimes when someone has an Achilles tendinopathy, he's a bit scared, or they don't really know what's going on. So we provided some knowledge about their condition. We told them what's having Achilles tendinopathy, how that occurs, what to expect about it, how to self-manage. We told them they need to understand that they are their own physios, you know. So it's like they need. We provided them a pain monitoring system and told them like a little bit of pain, acceptable pain was all right, but that they had to avoid having flare-ups, okay? So we told them activity is all right, but just make sure the next day you are the same, that doesn't get worse, okay? So we provided clear progression and regression guidelines. So we provided a four-level exercise program. Starting with first, depending if they had like very irritative pain, we were invited them to do just isometrics. If the pain was acceptable, we were asking them to do some triceps uri strengthening, like calf raises, seated calf raises, and also 2 exercises of the kinetic chain, like hip abductors and hip extensors. And we also invited them to do some double leg hops that they had to start doing if they were able to do them without flaring up. So one day we were asking them, like, can you do 20 double leg hops? If that wasn't flaring them up for next day, then they were invited to do a double leg hops program every second day, okay? But as soon as they were able to do 10 single leg hops, then they had to stop doing double leg hops and skip to 1 day of single leg hops per week, plus start running twice per week, okay? That's what we paid them. And yeah, and we were offering ourselves for regular feedback, okay? So we were always happy to attend them or to listen to them, or yeah, to help them with the progression.
And did you find that they were quite reliant on you for regular contact, or did it vary between individual participants?
Well, some of them were contacting me, were sending me emails, hey, Igor, I did this, and that's fine, and others you don't hear about them, okay? But this is the funny thing, because well, if we go, we can talk later about the results, about what the good things and the bad things, but we need to talk about this, because in the beginning everybody said like that the education, the provided education was a like super positive thing of the program, but then the reality was another one. Okay.
Okay, excellent. Anything else to touch on in and around the progressive exercise program, or that probably covers? I think that covers.
Yeah, I think that's enough. Maybe with the results we can go deeper on this.
All right. So then, in terms of your primary and secondary outcomes, you've got some clearly laid out primary primary outcomes to start with. Do you just want to talk through what your primary outcomes and what you're looking for?
Sure. So based that this is a feasibility study, okay? Mm-hmm. So for people that might not know what a feasibility study, it's like the preliminary approach previous to a trial, okay? So we didn't want to know if the treatment we were providing them was good or not. We just wanted to know if the intervention was appropriate or not for a future trial, okay? So our primary outcome was we wanted to know if the rate of recruitment was good, if the rate of retention was good. We wanted to know how patients, the feedback that they were giving us, the acceptability of the interventions. We wanted to know how they were the adherence, how the adherence and the fidelity to the exercises was, and we also wanted to know if we were having some adverse events, for example. Okay, so that's the first aim of the study. Of course, as the secondary outcome, we also saw if they were improving or not. Yeah, but that was not that wasn't our primary outcome. The primary outcome was to see if it was feasible and if we could later conduct a bigger study, okay, and be confident that the intervention was all right.
All right, so now on to the results, Igor. Do you want to tell us a little bit about what your main findings were?
Yeah, so the main findings were that most of the feasibility outcomes were good. So the rate of recruitment was 100%. So 15 of the guys that we asked to take part, they came on board. The rate of retention was 87%, so only 2 of them dropped out, okay? And the reason was lack of time to complete the exercises. Response rate to outcomes was good, 93%. And in terms of acceptability of the interventions, this is interesting. Well, the positive things, they rated as positive things of the program, the provided education, the appreciated improvement alongside the treatment, and the continuous feedback that we provided, okay? And the negative things of the program were the time burden, the program commitment, and the necessity to go daily to the gym. Okay, so all the time that they needed to do the program. Okay, in terms of exercises, the adherence was quite good, was 70%, but it was different depending on the exercise. Okay, so what we found is that for those exercises where they needed to go to the gym, the adherence was lower. But for exercises that they could do anywhere, at home or in the park or whatever, like hopping, the adherence was good. However, fidelity was quite poor. Fidelity was 50%. Okay, this is something that I have to tell you that surprised me, because like the whole time they were saying like, yeah, the education is good, we understand everything we do. I am doing exactly what you say, but then when they provided the Excel spreadsheet where they had written all the exercises they were doing, that was nothing to do with what I told them to do, okay? So yeah, they were very happy, but they were not doing what I told them to do. And the other thing, the other issue, and my other concern, and it's also related, I guess, to this, is that we had 3 adverse events. So 3 guys did more than I asked them to do, okay? So one of them was a sevens rugby referee, and he wanted to be super fast. So he had a tendinopathy, he was recovering, but he started to do uphill speed sessions, okay? Uphill speed sets. And also while he was doing all the gym stuff, okay? So he had a small gastrocnemius tear. Another guy had the same problem playing basketball. Mm-hmm. And then a third guy tore his collateral knee ligament playing football. So these were activities that we didn't say, no, this is forbidden, but we told them to pay attention to that, okay? So, okay, you are recovering, we don't want you to flare up, stop doing these kind of things, but it's like, so maybe for a future trial, we would ask them to stop these activities, okay? And even if they say that the education and the exercises are clear, that this is, of course, something that we need to improve for a future trial, okay? In terms of secondary findings, well, there was a significant improvement for visa A with an effect size of 0.74. There was a significant improvement in pain. There was a significant improvement in strength outcomes, like for triceps surae, for heel rises and seated calf rises. also for leg extension. So everything was good, okay? And a new thing here, a new finding is that if we look at hopping, what we measured was leg stiffness during hopping, in maximal hopping on the spot, but we also asked them to do some hopping to fatigue. And what we found is that leg stiffness, so the efficiency during hopping had improved like progressively in 12 weeks. So they, at the end of the 12 weeks, they were able to hop in a more efficient way and to keep this efficiency during more time. So that's a positive thing, okay? But that's secondary outcomes. So at the end of the day, what the conclusion would be like, I think that we can be a little bit more aggressive, but before we say this, we need to restore, or we need to see how we are gonna fix this adverse events thing and this education thing, okay? We need to, so we can say that a pain-guided hopping intervention is feasible, but we need to fix these two things, because that cannot happen again, okay? We need to improve education, and we need to make the message how to say, yeah, they need to get the message more clear, okay? That's the thing.
You mentioned there being potentially a little bit more aggressive with the plan. Is that going to be related to the volume or the intensity, or is it going to relate back to the NRS or the pain scale that the individual is working to? Have you got an idea of how you're going to be doing that?
Well, that's the thing. That's a little bit related to another paper another study that we are doing now. Another thing is, like, as physios, we rely a lot on our experience, but to quantify loads is difficult, you know? There's not much there. So another study, what we are doing is like, okay, we know as clinicians, we ask them to do heel rises, double leg hops, single leg hops, overweight, heel rises with overweight on the step. But we don't know how to quantify that. We don't know what's the differences between doing an overweight heel rise or a double leg hop. We don't know what is more loads for the Achilles tendon. So we are now doing a study on that. So we want to measure. We have measured Achilles tendon forces in different exercises that we prescribe to our patients, and also to exercises that the runners do, like skipping or things like that, okay? Because we want to see where the Achilles tendon loads are higher. So maybe we can progress them better, okay? That's one thing. That's one of the other studies we are doing. And the next study we need to do is a qualitative study to see what are the barriers, you know, where does the message get stuck or stopped, you know? Why if I tell you something and you tell me you understand it, you don't do what I say? You understand?
Yeah, absolutely. And bearing in mind this is just a feasibility study, but is there any particular components of it or lessons that you've learned that you think will be really applicable to clinicians in practice that are working with people with Achilles tendinopathy? What parts of this could they perhaps take out, or what would you advise people specifically as a result of really this study? Has it changed your practice, and what would you sort of recommend, or how would you advise new clinicians working with Achilles that they might be able to think differently as a result of this type of study?
Yeah, well, as I said, like, I had the feeling that there was a gap between the re-up that we usually do and the aim that of the athletes that are injured. Okay, so like differences between slow loads to fast loads. And sometimes I think, like, the physios, because we are a little bit scared, might be a little bit conservative. So I think that if we are using a pain monitoring system and we educate our patients, we can be a little bit more aggressive. Like, we can start with some hops, we can start doing some running. And I don't think that, but this is my bias, okay? So I don't think that everybody needs necessarily to go to isometrics strength, functional strength. I don't think everybody needs to do that, okay? Because we are always treating different athletes, and some of them are gonna be strong since the beginning and might recover faster, okay? So I think we need to tailor this individually. Okay, but I would say to clinicians that to use a pain monitoring system and not to be scared.
Fantastic. I think that's a good point to start to close the conversation on. It's been really fantastic to hear about your background there and how you got to produce a paper like this that's out there in physical therapies in sport. I'll certainly include a copy of the link to this in the show notes. Is there anything else that you'd like to add, or you think we've pretty much covered most of what we wanted to today?
No, really, Tim, I just wanted to say thank you, because I think you are doing a good job. I think it's important to translate what researchers do to clinicians, because also I think there's a big difference between old school clinicians and people that are coming from the universities now. This is my experience in Spain. I mean, I never heard about research when I was at school, at physiotherapy school. So I think it's important to fill this gap, and I think that it's important to find the right way to reach to this, like clinicians that are in the clinic that have been working there for 20-25 years and are not so used to read papers and to read research. I think it's important to get to them, okay? Because I mean, like, otherwise we are going to have two different physiotherapists in the world, you know, like old school, that more passive and now everything is active now. And yeah, I think we need to link both.
Absolutely. And if people want to follow your research a little bit more, as I'm sure they will, where's the best place for them to find you? Where are you kind of active online these days?
Well, I have a Twitter account that it's at Sancho. How do you say this? Low dash, Igor? Underscore, I don't know. Yeah. So at Sancho _Igor. And my mail, if someone wants to drop me an email, is physioigorsancho@gmail.com. Okay. I will happy to respond any questions.